Dr. Jorgensen, R1, will be doing this presentation.
Hi, I'm Tom. Thanks for listening to my talk. Okay, so thanks for the introductory. So I'll get right into it. This is the myth we're looking to try to bust. So first thing I wanted to talk about was just the fact that the story kind of follows a path of penduluming recommendations and scientific ideas, and this is just a digital piece of art I found online that's titled Miasma. And to go into a little bit of what that means, miasma was the theory of infectious spread that was probably developed around the 5th century BC, likely by Hippocrates, that suggested that a lot or essentially all of the infectious transmission that were happening in communities were due to bad air. Either contaminated air or air infected with foul smells or things that were coming from poorer and more crowded communities, and that the transmission of disease was through the air itself. Does anybody, this is the wrong guy, can't let AI make your presentations. Does anybody know who this is? This is Mr. John Snow, who was a scientist and doctor in London in the 1800s. And is credited for instituting one of the first scientific-based public health interventions when he determined that cholera, which at the time was thought to be caused by miasma, was actually caused by fecal-oral transmission through the water supply. And one of the first public health interventions that we know in the modern era is when he decided to take the handle off of the Broad Street well in London, thereby ending the cholera outbreak in his neighborhood. So with this came a lot of changes in the idea of infectious transmission, and the idea of air transmission and miasma kind of became a thing of the past, to the point where you have Dr. Charles Chapin, who was the director of public health for Rhode Island, in a book he wrote in 1912, was talking about how this idea that the idea of air transmitting disease was kind of a thing of a past. It was considered to be something before, but that now it was of minor importance in the spread of disease. So kind of trying to leave this behind as the idea of more the germ theory and other infectious spreads were thought to be more cutting edge. So that was all well and good until around 1955 when Dr. William Wells, through a very scientifically heavy and complex book, did some experiments with aerosolized particles with essentially an aerosol generator, who determined that some particles didn't necessarily follow the laws of gravity. They didn't just fall when they were coughed out of people's lungs, but that there were some particles that actually evaporated faster than gravity could act on them, leading to them either rising or at the very least hovering in the air for multiple minutes or hours at a time. And furthermore, that some of these particles could even be housing for infectious pathogens. Of course, at the time people were thinking about tuberculosis, but this was able to be extrapolated to other diseases as well. This holds pretty soundly with what we understand to be airborne transmission today. Dr. Wells at the time probably got the threshold for the size of particle that was transmissible at the time wrong. He believed it was about 200 micrometers, and we know now today that threshold for that particle becoming airborne is more likely to be about under 5 micrometers, but he was pretty close considering the time. So just to kind of go over what we mean when we talk about aerosols as we get into the rest of this talk, aerosols are polydispersed droplets and particles that can remain suspended in air currents and can drift considerable distances and are likely under the size of 5 micrometers. The actual terminology of aerosols is used by different folks in different papers to mean different things, and it can be a bit confusing. There's some new recommendations concerning the language, but for now, and according to the scope of this talk, that will be our running definition for aerosols. So does anybody know what this is? Anybody remember this day by any chance? Anybody want to shout it out?
When the NBA shut down.
Yeah, so this was, at least from my perspective, kind of when in the U.S. COVID really became, at least in my head, when the pandemic kind of started at a really aggressive rate. And as Dr. Freed was saying before, one of the biggest points about this time was that things moved really, really fast. Recommendations came and went without a ton of evidence to back them up, and they disappeared just as quickly. This is March 2020. I'll just let y'all read this really quickly, but it's a WHO official post on Facebook that definitively said that COVID was not airborne, that this was a complete myth. And so So you can imagine, as time went on, by July 2020, there was an open letter from leading experts and public health agencies who said that we might want to rethink that. And then by May of 2021, there was an article published in The Lancet that definitively said that COVID should be considered to be airborne. And as this was happening, people were realizing that COVID was a lot more infectious and scary than originally thought. And so what resulted from there is that without much evidence, but with the knowledge that COVID was likely airborne, multiple different public health agencies started to identify certain procedures as what they called aerosol generating. So the idea was that specific procedures, including intubation, extubation, high flow nasal cannula, CPAP, BiPAP, were all procedures that should be considered to be infectious causing, generating these small particles that could lead to the transmission of COVID. Again, there wasn't a lot of, I really looked, there really wasn't a lot of evidence that was cited to prove these points. They were, and from what I can tell, and a lot of the evidence has been, other recommendations have been withdrawn at this point, but from what I can tell, it was just kind of based on a common sense approach, which we know at this point is not really a good basis for science. Yeah, so this is kind of how the myth was born. So with this in mind, some other scientists and folks decided that it would be a good idea to formally test this theory. So here's a 2021 study, risk of aerosol formation during high flow nasal cannula treatment in critically ill subject. So this looked at 3 healthy subjects and 17 subjects with respiratory disease, some of which were COVID, some of which were not. And they looked at high flow nasal cannula and compared that to conventional nasal oxygen therapy using a laser light scattering and handheld particle counters to determine the amount of aerosols that were dispersed. Long story short, high flow cannula was not associated with any formation of aerosols compared to the conventional oxygen therapy. And from this study, they determined that there was no real increased risk of transmission of COVID to healthcare workers while using high flow nasal cannula. 2023, nasopharyngeal SARS-CoV may not be dispersed by high flow nasal cannula. 17 patients with nasopharyngeal confirmation of COVID RNA, and they looked at conventional nasal cannulus with nasal cannulus with high flow nasal cannula, very similar to the last study, but for this they used just took air samples at 0.5 meters and 3 meters away, and then just ran PCR to see what they found. Again, no real difference between the regular nasal cannula and high flow nasal cannula, and no sample was statistically significant for identifying COVID between the 2 groups. Another one, aerosol emission and exposure in non-invasive ventilation, 2025. These did look at healthy volunteers, not folks with COVID, but did look at CPAP, high flow nasal cannula, and no breathing aid. So they measured aerosol emissions with a portable aerosol spectrometer, and they had the subjects breathe normally, breathe deeply, to cough, and to read a passage aloud. And then there was no indication that CPAP or high flow nasal cannula increased aerosol generation across any of these activities. 2021 study by Hamilton and Co. This one was my favorite, actually, so I gave it 2 slides. Aerosol emission from the respiratory tract and an analysis of aerosol generation from oxygen delivery systems. So this took 8 healthy subjects and 8 with COVID who were instructed to breathe, speak, and cough using no breathing assistance, CPAP, and high flow nasal cannula. So they used 2 different aerosol measuring devices, which measured different droplet sizes but correlated at around the 5 micrometer mark. And they also noted that these 2 devices correlated pretty heavily when used in control subjects and assessed what the difference in aerosol generation was between all of these modalities and metrics. So for CPAP, they actually noted that with coughing, breathing, and speaking, that the generation of aerosol was actually reduced while subjects were using CPAP. I think the easiest explanation for this was that CPAP is in and of itself a mask. It is going to block some of these transmissions as they come from the human lung. Even when they induced an artificially large air leak in the CPAP mask, they still found this effect, that CPAP demonstrated less aerosol generation than folks without using any breathing aid. And then they actually, when they did the high-flow nasal cannula study, for a moment they actually thought that they'd found something, that there was indication that high-flow nasal cannula did show a dose-dependent relationship in aerosol generation. Essentially, when they turned up the high-flow nasal cannula, they did find higher degrees of aerosol generation versus lower flows of high flow and compared to folks not using high flow at all. They looked a little bit closer after they found these results and noted that the aerosol generation was happening was very machine dependent, and even when they removed the machine from the patients themselves, they were getting essentially the same results. They also noted that the sizes of the particles and the nature of the particles were not quite consistent with particles that were coming out of the human lungs. So they looked a little bit closer than that and noted that when they put a filter device between the high flow nasal cannula and the patient, that there was essentially no aerosol generation, fixing the problem. Essentially what was probably happening is that the machines were leaky and were just generating aerosols before they ever made it to the patient, which of course would not generate infectious particles. At the conclusion of the study, they determined that CPAP and high-flow nasal cannula should not be deemed aerosol-generating procedures. And then to kind of put this all together, there was a meta-analysis in 2023 by Zhang and co. Called The Generation of Aerosols by Non-Invasive Respiratory Support Modalities. Looked at 24 different studies. 12 included included patients, and 15 just selected healthy volunteers, and looked at the aerosol generation in non-invasive ventilation and high-flow nasal cannula. None of the studies they found demonstrated an association between non-invasive ventilation and pathogen-related aerosol generation. And just to share this quote, no study reported clinically relevant increases in aerosol particle production by high-flow nasal oxygen or non-invasive ventilation, which is pretty, for me at least, cinches it pretty well. And here's just the, this is the graphic interpretation of that previous meta-analysis, which, and this is for high-flow nasal cannula specifically, which showed essentially no link between aerosol generation and high-flow nasal cannula. You might notice that third study right there, which seems to at least be leaning toward a link. That was that previous study with the leaky nasal cannula that we discussed earlier. So other than that, there really is no good link there. And then essentially, and the reason there's only 4 listed here is just because these were the ones that specifically included COVID patients and were referring to high-flow nasal cannula. And then essentially the same deal for CPAP. There's really no good link, either meta-analysis or in individual studies, between non-invasive ventilation and the generation of aerosols. And again, only 2 here because these were the ones that included COVID patients. So what all happened with all of these results and changes? To kind of come back to our story here, in June of 2022, the NHS did a similar review to assess what should and should not be on the list of aerosol-generating procedures. They looked at non-invasive ventilation, looked at 7 different studies, and recommended that non-invasive ventilation be removed from that list. Same for high-flow nasal cannula, looked at 9 studies and also recommended that it be removed from the list. For this third point, not really the scope of what we're talking about today, but I just thought it was interesting, so I included it. They also recommended that in paralyzed patients who are undergoing tracheal intubation and extubation, they looked at 3 studies, each which had consistent results, that showed that there was not much aerosol generation in subjects who were being intubated or extubated under paralysis. And in fact, they actually demonstrated lower aerosol generation in these conditions than folks just with normal respiratory activities. And they did recommend removing routine intubation and extubation from the AGP list. Of course, they did not include emergent intubation and extubation, as that is pretty difficult to study, so I would not go so far as to say that that should be included on that list. What they did recommend keeping, though, was EGD, any kind of respiratory, sinus, or dental or ENT surgeries, as those were probably linked, either inconclusive or probably linked to the greater generation of aerosols. The CDC, on the other hand, we have not quite caught up. We've last updated our guidelines in 2024, and the guidelines to this day, I've looked it up recently, still do include BiPAP and CPAP and high-flow nasal cannula in the list of aerosol-generating procedures. So to conclude here, according to currently available data, it's really hard to say definitively that high-flow nasal cannula and non-invasive ventilation cause infectious aerosolized particles, and it's pretty clear that they don't. In fact, CPAP may cause a decreased risk of COVID transmission and the generation of aerosol particles. And while some national governing bodies have updated their recommendation, others have not, and the myth persists. Thanks so much. These are some references.
Okay, any comments? Dr. Fitzgibbons.
This was a great talk. Really great talk. The other factor to keep in mind is the variable speed with which the regulatory agencies like Cal OSHA and other regulatory agencies were able to respond in the timeline. So it's one thing to try to keep up with what our international, national public health bodies are saying, but when the goalposts are also set in a different location with regards to the rules, and then you're trying to keep hundreds, or indeed it was about 3,000 patient-facing healthcare workers safe. And just for context for everyone to remember, we had 5 full medical surgical units in addition to 2 ICUs full of patients with COVID during these 2 winters and one of the summers. And at any given time of that, I think at peak 110 patients in the hospital, at any given time, about half of them ended up on high flow nasal cannula or more. That's not even counting CPAP. The implications of knowing whether this was aerosol generating or not was immense. And so I'm really glad to know the answer now.
So am I. I think, I'm not sure. The recommendations were in the beginning, like, as you saw, were not to be using any of these things. And I think we were using them anyway, at least for part of the time, before the recommendations changed. Some of that was based on some of the data that was coming out. That wasn't, like you said, it takes time to get through these regulatory agencies and the recommendations even then, even though they were coming out with them relatively quickly. But I think that a lot more people would have been intubated and put on ventilators had we not been doing that, for sure. Any other comments? Questions? Okay. So, is it a myth? Non-invasive ventilation and high-flow nasal cannula are aerosol-generating procedures. How many people think this is true, confirmed? How many think it's plausible still? How many think this is busted? That's also unanimous. All right, great. All right, we're busted.